Let us discuss a few aspects on the beta thalassemia. Beta thalassemia, because we have seen in detail about the alpha thalassemia and the related problems and beta thalassemia, we are going to see in this video. So what are the important things about beta thalassemia to know? But most importantly, the beta thalassemia is usually due to the mutations. That's what is going to cause. Beta thalassemia is due to mutations, typically point mutations than frame shift mutations. So typically the point mutations are the ones that are going to cause beta thalassemia, unlike alpha thalassemia, which are typically due to gene deletions, not due to point mutations or frame shift mutations. It's due to gene deletions, alpha thalassemia, but here it's due to point mutations or frame shift mutations. So beta thalassemia also, technically speaking, genetically you have two types. One is called beta 0 and beta plus type. In beta 0, where a particular allele or a gene, for example, we are always talking about one from one parent only. So one parent, particular allele or a gene from that particular parent, if you want to call that as beta 0. But in beta thalassemia, it's relatively quite simple, because there are no two genes. There is only a single gene inherited from each parent. So gene becomes equal to that of an allele, that gives equal to that of a beta chain. So there is no complication here like alpha thalassemia. So it's a single gene, single allele. So beta 0. So beta 0 means literally no beta globin chain is synthesized. No beta globin chain synthesized from that particular affected allele or a gene. So if you tell beta plus, then it means some beta globin chain is synthesized from that affected gene or an affected allele from that particular parent. I mean, they're inherited in the mutated thing, but there is some production from that particular mutated allele or a gene. So that's what the idea is. So how come this possible? In alpha, gene deletion is quite simple. You know very well, isn't it? So you have one side, you have alpha, like that gene on one allele. If you're showing alpha gene deletions, depending on that whether 1 or 2 or 3 or 4, you're going to get different alpha 0 or alpha plus. We discussed in detail. But how a single gene, but how one mutation is causing no beta globin gene production, but another mutation is causing a completely different, like some beta globin gene production. It depends on where the mutation is. I already told you, whenever you take a gene, if you take this is a gene, you have a promoter in the initially, then you'll have a stop codon here. So which means this is the area, and you have a lot of exons filled with a lot of introns in between. Exons are there filled with a lot of introns in between. So these are the exons and these are the introns, and these are the introns. And when you are going to transcript this into an mRNA, you are only going to produce a completely exon. I mean, when you produce an mRNA, you are going to produce an mRNA with exon as well as an intron. So you're going to produce an mRNA with exon as well as intron. I told you these are the exon, red one are the exon sequences, and blue ones are the intron sequences. But then this is the primary mRNA. This will go for something called splicing, post-translation modification in the form of splicing. So you are finally only going to remove all the intron segments. So intron segments will be intron. Here in this, 2 intron sequences are there which will be removed. Intron sequence will be removed in something called post-transcriptional modification process, and you will get only the exon, which is nothing but the coding sequences, and this will be translated into beta chain. So this is how it's going to work. So this is what we called as a splicing. So this one of the post-transcriptional modification is what we called as a splicing mechanism. So why I told you this is to understand what is the basic idea of producing this beta 0 and beta plus. So if the patient is having an exon mutation, they very likely tend to be causing beta 0. Exon mutation. Typically this exon mutation tend to create a stop codon, premature stop codon in between, which means for example, they'll produce a premature stop codon here, which means there'll be no mRNA synthesis at all. There'll be no beta globin chain synthesis at all. So that is what we called as a beta 0. Usually that is the reason why you get a beta 0. If you ask why you get a beta plus, in this condition it is either due to an intron mutation, that is otherwise referred to as splicing mutations, because introns are removed by splicing. So that's why these are also called as intron mutations or splicing mutations. Or if the promoter mutations will not affect the gene completely, because promoters only these are like enhancers. They enhance the transcription. So which means when you have a promoter mutation, the enhancement will be less, but some gene production, chain production will still be happening. Some transcription will still be happening from that particular gene. So when you get an intron or a promoter mutation, it typically results in beta plus variant. Some will be produced. When it is a exon mutation, you will typically result in a beta 0. Clear? So this is what is going to happen in a beta thalassemia. So this is the basics of understanding. Like an alpha thalassemia, you can put a genetic classification also for beta thalassemia. If you ask me what is the genetic classification for a beta thalassemia, again I can write here as homozygous, I can write here as heterozygous, and I can put beta 0 as the clinical condition and beta plus as the clinical condition. So what happens in a beta 0 homozygous, which means both the genes are mutated in such a way that both are showing beta 0, which means absolutely in this patient no beta globin chain is produced in the first place. Absolutely no beta globin chain synthesized at all in the first place. In this condition, this is what is going to result typically in something called a thalassemia major, or otherwise referred to as a Cooley's anemia, and this patient is going to be completely transfusion dependent. So what about heterozygous? When you ask about heterozygous beta 0, which means one is affected and other gene is normal. Fortunately, one particular parent or gives rise to one allele that contains only one gene in the beta. Unlike alpha, there are two genes I told you. But here one is affected, mutated, and the other one tends to be completely normal. So this tends to be completely normal, right? So this is what is happening here. So which means, I'll tell you what this will happen. So what do you mean by homozygous beta plus? In the sense you have beta plus as well as beta plus in both, which means both are going to show a similar mutation. Mom side also you have a beta plus, some mutation that is causing beta plus, some gene is produced. In the father side also you are having some mutation in the beta gene that's producing some globin chain. So that is beta plus. So beta plus, so this is something different. We'll see what will happen. And finally, if you ask me, heterozygous beta plus means one is beta plus and other is normal. So which means one is completely normal, one is showing a beta plus. So this is the heterozygous. So this heterozygous mutation, that is at least one beta globin gene, is normal. This condition typically is going to result in something called a thalassemia minor. That is a beta thalassemia minor or a thalassemia trait. That's what we're going to call it. So this is what is going to create something called a beta thalassemia minor or a beta thalassemia trait. Very commonly, but very, very rarely they can result in intermediate-like picture, but very rare. I'll tell you why. But in general, at least if at least one beta gene is normal, you will result in only a minor or a trait, where the HB electrophoresis is going to show HbA2 more than 3.5%, and you are going to have a asymptomatic patient without any clinical features of thalassemia at all, but you might get some slight increase in RBC count and low MCV and all these things. Mild anemia may be there. All these things are possible. But apart from that, there is no symptoms in the patient, or there is no transfusion dependency. But this beta plus is highly variable. So how they can present is variable, but very commonly they are going to present as a thalassemia intermedia, so or a thalassemia major. So what is the inference from these things is, usually when both the genes are affected in homozygous states, typically the disease tends to be relatively more severe, or at least intermediate disease. You will not get a minor disease. But in heterozygous states, at least one gene is abnormal. Typically you will get a minor disease. Very commonly you will get a minor disease or a very mild disease. If at least one gene is normal, and if both is affected, you will get a little bit severe or at least an intermediate disease. So this is what is going to happen. So this is the difference between homozygous and heterozygous. What do you mean by compound heterozygous? Here, can you get a common heterozygous? Yes, absolutely possible. What if one is beta 0 and another is beta plus? Yeah, absolutely possible. So which means from one gene, no chain, alpha chain, beta chain synthesis possible. From another gene, some alpha gene, beta gene synthesis at least possible. So what do you get by this? Typically you will result in a major picture. When both the genes are affected, I told you, this common heterozygotes, again they are going to result in a thalassemia major only, or they can result in a thalassemia intermedia also, rarely. So depending on how much beta chains are produced, all these things depends on how much beta chains are typically produced from that particular variant. So what I can tell is now, I can tell one more thing, like what are the variants that give rise to major, minor or intermedia? Typically, if you ask me, this beta 0, major means always it is beta 0 only. So beta 0 typically results in major only, always, this is always, most of the time. And minor means usually most of the times it's going to result in only beta 0 beta or a beta plus beta. This is very simple, fairly straightforward. At least one gene normal, definitely minor. At least both are abnormal, it's going to result in major. But remember, intermedia is something that can come in any way. So for example, this beta plus beta 0 or beta, I can write as beta 0 beta plus, can produce major or can produce, this common heterozygotes can produce intermedia also. At the same time, very rarely, your beta plus, this is a homozygous, can produce intermedia also, but beta plus can produce major also, depending on how much the beta change, because both are affected. Whenever both are affected, you can think either they can produce intermedia or they can produce major. That's why I'm writing here. But in exceptionally rare scenarios, even heterozygotes, beta 0 beta or beta plus beta can also produce an intermedia picture. So how come this is possible? Why these things are happening, and why sometimes a minor is producing intermedia picture? Which means whenever you expect a minor, means whenever you see an heterozygote, means you are expecting a less severe picture, but why relatively a more severe picture? Similarly, when you are expecting both the genes are affected, relatively more severe picture you are expecting, but why you are also seeing a less severe picture like intermedia, even when both the genes are affected? What is the reasons for all these things? Let me tell you. So for example, in homozygotes and in heterozygotes, in homozygotes we expect severe. For example, you are expecting a major, expecting a severe disease like a thalassemia major, but the patient is having a less severe disease. Like intermedia or sometimes even a minor. But this will be the clinical feature, less severe like intermedia. Why? What is the reason behind all these things? Number one, first reason is, when you expect a major disease but the patient is not having a major disease but having only intermedia or even sometimes a rare scenario minor diseases, because they might have associated alpha gene deletions. I already told you, the moment you have associated alpha gene deletions, which means in beta thalassemia this will be reduced, the beta chain production will be reduced in beta thalassemia, but in alpha gene deletions will result in decline in alpha gene production also, which means the imbalance is reduced. Imbalance between the alpha and beta thalassemia is reduced. That is the reason why we expect a severe disease but the patient might have a milder disease. Number two, so you can co-inherit a condition which produce increased gamma chain production. Co-inherit condition that produce increased gamma chain production, like hereditary percent of fetal hemoglobin and all. So whenever you co-inherit conditions that increase gamma chain production, which means you will increase the HbF. I am telling you, HbF is actually protective for thalassemia, especially beta thalassemia. HbF is protective for thalassemia. So whatever condition that increase the HbF production is going to have a very protective nature. So example, you can write as something called promoter mutation, like BCL11A mutations are there. So this a simple condition produces hereditary percent of fetal hemoglobin. Because of that, you might have excessive HbF production. Because of that, you might have less severe disease. But in heterozygotes, which means one beta gene is normal, at least one beta is at least normal in heterozygotes, which means in this condition you expect mild disease, but sometimes clinical features may show that the patient is having more severe disease. Like for example, intermedia. More severe disease like intermedia, but why? Simple, exact reverse of what you have seen in the homozygotes. So they can have additional alpha genes, which means patient may have 5 alpha genes instead of 4. Additional alpha genes will actually cause more instability in a beta thalassemia patient. I already told you, similar reason. So that is the reason why you might result in this condition. So you have another condition called a dominant beta thalassemia. But I didn't tell you this fact, all the thalassemias are autosomal recessive inheritance. All thalassemias, whether alpha or beta doesn't matter, they are autosomal recessive inheritance. So that's an important point. But there is a condition called a dominant beta thalassemia. What do you mean by dominant beta thalassemia? For example, in a heterozygote, you expect to be something called a beta 0 beta or a beta plus beta. So these are the phenotypes you expect in a heterozygote. So actually this should be autosomal recessive, but if it's not innate and autosomal recessive, but innate and autosomal dominant fashion, which means these genes are inherited as dominant fashion. This is what we call as dominant beta thalassemia. In this condition where the affected gene is becoming a dominant gene, which means that is the one that is driving the cell. So in this condition also will result in a relatively more severe disease than expected. So these are the conditions where you expect a severe disease but it's less severe than expected, and there are some conditions where you expect a less severe disease but the clinical feature is relatively more severe than you expect. So these are some of the genetic interplays that are very, very important, crucial in understanding. Then come to the clinical classification of a beta thalassemia and what are the differences clinically. You will expect in a thalassemia major, or you will expect in a thalassemia intermedia, and what you will expect in a thalassemia minor. If you ask me what are the clinical features that give rise to the difference in major minor, but anyway the most important difference, the most important of all time is what you have to know is both will have clinical features of thalassemia, but this patient tends to be asymptomatic. You will have no clinical features of thalassemia, and the clinical features between these two will be highly overlapping. Even though some difference I'm going to tell in the subsequent, this is the overview, basic. There will be a lot of overlapping of clinical features will be there, but these are completely different. Mine is completely asymptomatic. But if you ask me about the transfusion dependency, that's where the key is. Transfusion dependency wise, if you ask me major, they are completely transfusion dependent thalassemias, which means they need regular transfusions throughout their life. But intermedia, the most important difference is they are non-transfusion dependent thalassemia, which means they need only occasional transfusions, not regular transfusions. But these patients do not develop any complications at all. They are not needing any transfusions for their entire life. So unless until other conditions that necessitate transfusion, apart from that, they don't need transfusions for the sake of the thalassemia. So then what about the complications? Complications wise, if you ask me, so again there will be complications in both these cases, and again a lot of complications will overlap with each other. Something will be more in major, something will be more in intermedia, but absolutely no complication in case of a thalassemia minor. So these are some of the overview things, but in general let us see the other differences between these three. What are the other differences between these three? First, what will be the age of presentation? Age of presentation, typically minor comes in adults only, and many of the times you are going to detect only incidentally unless until you screen in the childhood itself. Childhood, there are a lot of screening techniques which I will tell you, like Nestroftanol is there. Apart from that, adults it's typically incidentally detected minor. What about major? Major, typical age of presentation within 2 years, because they present with severe anemia. They have severe anemia, but definitely not at birth. Definitely not at birth. Generally they come around 6 months to 2 years of age. 6 months to 2 years of age, that is the typical age group where the beta thalassemia major Cooley's anemia presents with severe anemia. But apart from that, definitely not at birth. Only alpha thalassemia can present at birth, which I have discussed already enough. So usually this presents a little late, more than 2 years. That is the reason also why certain complications are relatively higher in an intermediate than a major, because they present late, not early. So they will have a mild to moderate anemia. So they won't have this thing. They will have only a moderate anemia will be there. It's an intermediate, so there are moderate anemia. So that's the next thing. What will be the hemoglobin levels at presentation? Hemoglobin will be typically less than 6 grams per deciliter. Here it will be usually more than or equal to 7 grams per deciliter. Here typically in the range of 9 to 11 grams per deciliter. So which means the patient, incidentally means the patient will be usually having only mild anemia, not moderate or severe. 9 to 11 grams per deciliter is a classic. Then what about the splenomegaly and all? Splenomegaly, pallor, jaundice, gallstones, skeletal deformities, because these are some of the clinical features. I told you there will be no clinical features in a minor because they are completely asymptomatic, but they can be seen in both thalassemia major as well as thalassemia intermedia. But actually, if I tell you, it is relatively more, severe and more significant significant in intermediate than major? Would you agree? But answer is yes. They are relatively more significant and more severe in intermediate cases only rather than major cases. Why? Because in major still, yes, they are present. You can get a pallor, you can get a jaundice, that's what they present with. You can get a splenomegaly, you can get gallstones, all these things. Gallstones will be typically bilirubin, pigmented stones because of hemolysis. Anyways, so all these things are possible. But why it is significant in intermediate and not in major? Because these patients come present with all these things, but you detect very early. You detect early and they can be suppressed with regular transfusions. Suppressed with regular transfusions, which means when you give regular transfusions, these complications can be suppressed. These clinical features can be typically suppressed, and when thalassemia patient who is well transfused and hemoglobin in the normal range may not even exhibit all these problems, whatever I mentioned, a major patient. But why significant in intermediate patients is because they present a bit late presentation. At the same time, they are not transfusion dependent, which means they don't receive any regular transfusion also, which means there will be persistent anemia, persistent splenomegaly for a long time. Since they don't receive transfusion also, these cannot be suppressed as well. That is the reason it becomes significant and little bit more severe over time in age in intermediate cases than major cases. But actually speaking, it can happen in both major as well as intermediate. That's why I told you a lot of overlapping clinical features will be there. Then when you come to the hematological data next, we already told about the hemoglobin and hematological data previously itself, but if you want about other hematological data to be told, I can tell about the RBC count. Typically it will be decreased in major and intermediate, whereas it's increased. It's a very, very important point. RBC count is typically increased in a minor patient. That is to compensate for the peripheral hemolysis. Because of that, your erythropoiesis will increase. But here in major and intermediate, why it is decreased? Because the erythropoiesis will be so ineffective in the marrow that they can't even cross the marrow and go out. So that is the reason why the RBC count is decreased in major and intermediate. Then if you ask you about MCV, will be decreased in all these three conditions. Typically, it will be in the range of less than 70. It will not exceed 70 most of the times in a thalassemia. MCV will be decreased. Then if you ask me about the hemoglobin electrophoresis, two important things are there. Hemoglobin electrophoresis, how we are going to detect is by HbA, and second is HbA2. What will be the level of HbA2? HbA will be completely absent usually, most of the times. And here it will be decreased but not absent. Here it will be slightly decreased. Here it will be very much decreased but not absent. Here it will be only slight reduction will be there in HbA. HbA2, in both these conditions it will be normal, where here it will be increased. This is what is the very, very important point. Normal in the sense both this will have HbA and HbA2 in the ratio within the range, that is normal is less than 3.5%. But whereas in a thalassemia minor, HbA2 means it's alpha to delta 2, we have already seen. So that will little bit increase, expand in minor, that is what we call, that is a feature in a thalassemia minor, that is HbA2 more than 3.5. Remember, alpha thalassemia trait or minor will have normal HbA electrophoresis. Only beta thalassemia minor will have HbA2 more than 3.5. Then what about hemoglobin F? Hemoglobin F will be increased in both, but hemoglobin F typically tends to be normal in case of a beta thalassemia minor. Which means increase in the sense how much it's increased, again it's very variable. Very variable. It is very overlapping. You cannot exactly determine the HbF and can tell that's major or a intermediate. Again, major and intermediate difference is based on transfusion dependency only. You cannot differentiate based on this. Only for theoretical reasons I am telling you all this. So HbF increase will be more than 50% here, but here it will be less than 50%. Here it will be normal. That's the key. But this and all will not typically differentiate a major from an intermediate. What about the iron indices? Iron indices, if you come to the iron indices, if you ask the serum iron and ferritin, that will be increased. Here it is variable, it can be normal or increased, it's completely normal. This is a very important point. Iron indices tends to be completely normal in case of a minor, there is no problem at all. In major, why it is increased is because of the regular transfusions. Because of the regular transfusions, patients will have definitely iron overload over time, most of the time. And here normal or increased because they receive occasional transfusions, still that's a risk of iron overload, which still they can pose risk of increased serum iron and serum ferritin. All these things are possible. If you ask me about the peripheral smear, so the moment I talk about the peripheral smear, So the most important thing is the anisopoikilocytosis, and the number of nucleated RBCs you see in the peripheral smear and all these things. Our nuclear RBC is a sign of more severe the ineffective erythropoiesis, more the nucleated RBC you are going to see in the peripheral smear, and more is going to be the anisopoikilocytosis. So by this feature, if you ask me in the peripheral smear, if you ask me about the anisopoikilocytosis, it's going to be very, very severe in case of a major. To an extent, it can be still seen in intermedia, and very, very less in case of a minor, which means you can put a plus or minus. Very, very less in case of a minor. So which means if you ask about the red cell distribution width, it can be increased in both major as well as intermedia, but typically it's normal in case of a thalassemia minor, again, which is a very important point of a thalassemia minor reduction. It is normal in case of a thalassemia minor. And typically if you ask about the complications, I told you complications, a lot of overlapping are there. The moment I tell about complications, none of the complications which I am going to tell is going to happen in a minor. So there is no complications at all in this particular patient. Minor means no complications. Major intermediate do have some complications, but which is more in which we'll see. Complication wise, if you ask me about the thrombotic complication, thrombosis very, very common in case of an intermediate, but rare in case of a minor because of regular transfusions. Similarly, pulmonary hypertension, very, very common in case of a intermediate, but very rare in case of minor. Again, pulmonary hypertension is due to hypoxia, anemia related, hypoxia related hypoxic ischemic vasoconstriction in the pulmonary vasculature. That is the reason why you get pulmonary hypertension. Regular transfusion will suppress the hypoxia and pulmonary vasoconstriction in case of a major patient. That's why it's very rare in major. Similarly, you will get the right heart failure. Right heart failure you can equate it to pulmonary hypertension, so which means again it's very common in a major, very rare in case, common intermediate, very rare in case of a minor. Similarly, if you ask about the left heart failure is actually quite common in major, very rare in case of a minor. Which means why left heart failure? I'll tell you the next point, then I can tell iron overload. Because iron overload is very common in a major, very rare in case of a minor. So that is the reason you can equate this left heart failure with iron overload and cardiomyopathy. The restrictive or hypertrophic cardiomyopathy may happen. Even dilated cardiomyopathy can happen with a second hemochromatosis patient, maybe primary or secondary. So these are the reasons why you get all these complications, something more in major, something more in intermediate. At the same time, if you ask me this leg ulcers, again intermediate has a high risk, surprisingly very important point compared to that of the major, because they are suppressed by regular transfusion. Similarly, extramedullary hematopoiesis, again very common in an intermediate than major, because again this can be extramedullary hematopoiesis can be suppressed by your regular transfusions. Similarly, endocrine complications like hypogonadism, diabetes, all these things again very common in a major, not in a minor, not in an intermediate. So why in major it's very common? Again because of iron overload. Iron overload is the reason for endocrine complications, and which is very common in a major. The reason is very simple. And hepatitis risk and all these things, hepatitis infections, all these risks are very common in major, again very rare in minor. The reason is because again regular transfusion itself poses a risk of variety of infections like HIV and hepatitis B, even a lot of blood-borne infections are there. So that is the reason why this is very common in a major, not in intermediate. Don't talk about minor and complications. You are not going to get any complications in a thalassemia minor by any chance. Then what are the genetics related changes? Genetics, if you ask me, what are the phenotypes you are going to get? Typically, major is going to result from homozygotes, and minor is going to result from heterozygotes. Minor is going to result from heterozygotes. Typically you are going to get in a beta 0 beta or a beta plus beta. So typically in heterozygotes only you will get a minor, and beta 0 that's where you get a major. Well known fact, but there are a lot of overlaps in the genetic between intermediate and this thing. So beta plus can cause intermediate, or beta plus can cause major also. Similarly, beta 0 plus can cause an intermediate, as well as beta 0 plus can cause a major also, because this is the overlap, because depending on amount of beta genes that are produced from each particular allelic fragments. But very rarely I told you this beta 0 heterozygotes, beta plus beta also can present with little bit of intermediate if they have associated alpha gene excess, or if there is some other dominant beta thalassemia also. In those conditions this is possible, otherwise this is not possible. So typically these are the genotypical variants. If you ask me about the hereditary co-inheritance of other thalassemias, co-inheritance of alpha thalassemia, then hereditary persistence of fetal hemoglobin, then delta thalassemia. All these things where it is common is very common in intermediate patients, very rare in case of a isolated major or a minor. Isolated major or minor, this is how they present. But intermediate cases, many times they have co-inheritance of other thalassemias also. Very, very common in intermediate clinical picture. But major and minor, generally they don't get all this co-inheritance. Treatment wise, you know very well. Treatment wise, they need regular transfusions, plus you need a lot of iron chelation. Here, usually generally they are not transfusion dependent, so NTDT, so they don't need daily transfusion, only you need occasional transfusion. You might need treatment for certain things, but still these are things, but these patients don't need any treatment at all. No treatment is needed for this patient. Lifelong they will be asymptomatic and they will be completely alright. So next we are going to the clinical features. Clinical features we are typically discussing on a thalassemia major, Cooley's anemia, because the moment you talk about major, I told you there are some overlap with intermedia also. The clinical features, you can't differentiate major versus intermedia. So there can be some overlap with intermedia, but ideally I want to discuss only on thalassemia major, what could be the clinical features. So that then you can expand into intermedia also. Minor, there is no point in discussing because there are no clinical features. Major wise, if you ask me what are the clinical features, the first one is the anemia. The moment I call up anemia is due to two reasons. One is due to ineffective erythropoiesis. One classically is due to ineffective erythropoiesis, and second one typically it is due to hemolysis in the periphery. These are two reasons why you get anemia. This itself will result in two problems. One complication, for example, this anemia itself may lead to a complication. This anemia, if it's long-standing anemia, this itself result in high output cardiac failure possible. This itself can result in a cardiac failure. That's different. All this pulmonary hypertension, right heart failure, every single thing might happen. So this itself can result in cardiac failure. Anemia itself, in a long-standing anemia itself can result in a cardiac failure. But this hemolysis and this ineffective erythropoiesis is going to result in two other peculiar complications. This long-standing hemolysis can result in something called gallstones. Highly possible. Long-standing hemolysis can result in gallstone. Typically, this gallstone will be bilirubin stones or pigment stones, pigmented stones. This ineffective erythropoiesis, in the long run, again, this ineffective erythropoiesis can result in itself a lot of complications. Like first thing is the bone marrow expansion. Normal bone marrow gets expanded. The moment normal bone marrow gets expanded, because of the ineffective erythropoiesis, it tries to expand the bone marrow to produce more and more blood cells, especially the RBCs. So because of the bone marrow expansion, this is due to accelerated hematopoiesis, you might result in catalytic phases called something called chipmunk phases, which is also referred to as something called rodent phase, like a rodent, which I'll show you the picture in some time. So this is what we call the chipmunk phase, or we are going to call it as something called a rodent phase. So what do you mean by chipmunk phase? You tend to have something called a frontal bossing. You tend to have depressed nasal bridge, expansion of the maxillary areas, and the central part will be inside and peripheries will be expanded. A lot of areas of skull will be depressed and some will be expanded. So this is what typically we call it as a rodent species or chipmunk phase. Chipmunk is something that climbs in the trees and you have this three, that marks on the back, isn't it? So I don't know how to tell it. So that's what we call chipmunk. So the face looks like something similar to that. That's what we call it as a chipmunk face. This is the first thing. And second thing, because the bone marrow expansion, you might also result in something called, in X-ray of the skull, you will see something called a hair on end appearance. Hair on end appearance, or something called a crew cut appearance. The reason for this hair on end appearance or a crew cut appearance is because you have the cortex. Inside you have the marrow. This dark line, thick line is the cortex, and the shaded one is the marrow. If you ask me, what happens is this marrow, this trabecular bone tends to expand. Because of the bone marrow expansion, they tend to expand out into the cortical bone. This looks like a hair, and I'll show the image. So this is what we call it as a hair on end or a crude event. That is due to bone marrow expansion, especially the marrow contains this cancellous and spongy bone, so that expands. So that's the reason for why you get a hair on end or a crew cut appearance. Number two, now one more thing you want to know is this hair on end appearance specific for thalassemia? No, it can be seen in thalassemia, all right, but it can be seen in other conditions like sickle cell disease. It can be seen in hereditary spherocytosis. It can also be seen in iron deficiency anemia. It can also be seen in cyanotic congenital heart disease. Cyanotic congenital heart disease you can also see in G6PD deficiencies. You can also see in certain cases of neuroblastomas. So why I split into two? Because in these conditions, these are very common. In this condition, cyan deficiency anemia, cyanotic congenital heart disease, G6PD deficiency, neuroblastoma, it is very rare. So these are the conditions that can produce your hair on appearance, so which means it's not specific for thalassemia anyways. Number two, if you ask me, the patient is also going to develop something called extramedullary hematopoiesis. What is the problem in extramedullary hematopoiesis? Because of the extramedullary hematopoiesis only, they're developing that massive splenomegaly and all these things. The moment you ask me about extramedullary hematopoiesis and whether it is a complication or not, sometimes it can be yes, it can lead to some complication. Yes, it can lead to some complications. What are the complications it can produce? Typically, if it happens near the spinal cord, for example, so this extramedullary hematopoiesis can present like mediastinal mass, even rib masses we have seen, because ribs get expanded tremendously on sides. It can mimic a mass-like lesion also. Sometimes mediastinal lymph nodes around may be enlarged because the lymph nodes start producing these red cells, and erythropoiesis start occurring in the lymph nodes also. So like you might get big mass-like tumor-like lesions. And second thing, you might get in the paraspinal masses. In the paraspinal region also, they can expand and they can produce paraspinal mass-like lesions. The problem with this paraspinal masses, they compress on the nearby spinal cord and they can produce a spinal cord compression, and they can even result in a paraplegia or a quadriplegia. All are possible, but these are very late and rare. By the contrary, extramedullary hematopoiesis is very common in intermedium than major. Why this is more common in intermediate than major is surprisingly because I told you extramedullary hematopoiesis can be easily suppressed by regular transfusion, which is the case in case of a major. But since intermediate patients don't receive regular transfusion, they are going to develop huge extramedullary hematopoietic tissues, and again they are at risk of developing all these extramedullary hematopoiesis related complications very commonly. And finally, third clinical feature. So this was the importance of the clinical features, and the second important thing is iron overload. Iron overload is a very important clinical feature of a major. Usually my intermedia is very rare to get iron overload, but the reason for iron overload is two things. Why in major? One is regular transfusions, and second one is ineffective erythropoiesis itself. Ineffective erythropoiesis itself. Whenever you have an ineffective erythropoiesis, you are going to increase the erythropoietin. Once you increase the erythropoietin, they are going to stimulate the colony forming unit erythroblast, because ineffective erythropoiesis, why it increases erythropoietin is because of hypoxia, peripheral hypoxia, continuing hypoxia. They are going to stimulate erythropoietin, which stimulates the colony forming units, which then produces erythroferron. In response to this erythropoietin, this erythroferron definitely is going to suppress hepcidin release. The moment they suppress this hepcidin release, you are going to have increased iron absorption from the GIT. Because of unregulated iron absorption from the GIT, this can also result in iron overload. So there are two reasons. You know why regular transfusions cause iron overload? Because each unit of a PRBC contains approximately 250 milligram of elemental iron. Everyone knows that. Almost 250 milligram of elemental iron is present in each unit of a PRBC. So again, with every transfusion you do, definitely you are loading the patient with a lot of iron. So definitely there is a risk of iron overload with regular transfusion measure. These are the two reasons why you get problems with these patients. And number three, you get is endocrine complications. Very wrong. And again, endocrine complications are, why they are happening is again because of iron overload state. Iron overload is the reason why you get endocrine complications as well. So if you ask me what are the endocrine complications you get, you might get hypogonadism. Hypogonadism means you get problems in the testis or ovaries, which is due to iron overload, which might cause something called hypergonadotropic hypogonadism, which we have discussed in endocrine already. Then you have something called pituitary failure also, because this iron can deposit in the pituitary also and get pituitary failure, which can result in hypogonadism again. Hypogonadism may be primary due to gonadal failure itself, or it can be secondary due to pituitary failure, which causes hypogonadotropic hypogonadism. Both are possible. Then you can result in diabetes mellitus. Typically hemochromatosis causes bronze diabetes, isn't it? But here not bronze, but just diabetes because of the pancreatic damage. Then since you don't have any gonadal hormones, no gonadal hormones or you can write as failure of gonadal hormones due to either pituitary failure or frank gonadal failure, you might result in osteoporosis, because no testosterone, no estrogen means patient is osteoporosis and risk of pathological fractures as well. So all these things are highly possible. These are some of the endocrine complications. Number 4, patients are at risk of infections itself, because I already told you infection risk again more common in major than minor, because anemia itself is a risk factor for infection, because itself is an immunosuppressed state. Apart from that, the transfusion itself increases the risk of lot of immunosuppression, and apart from that, chelating therapy, especially if you give deferoxamine, that itself increases the risk of certain infections like Yersinia infection, which we'll see in some time. So a lot of reasons why you get an infection in a thalassemia is there. So once you move on to this important investigations, we can move on to what are the clinical features we see. So I'm going to see in this slide. So if you want to know what are the clinical features, I'm going to discuss everything in one slide, because this is a hydrops and death in utero, typically due to 4 gene deletion, 4 alpha gene deletions. That's the reason, 4 alpha gene deletions. So this is a classic chipmunk facies, where you can see your depressed nasal bridge, expanded maxilla, and like the nose and all looks very prominent, and a little bit separation of the your eyes are there. Some element of hypertelorism will be there. That is because the expansion of the like sinuses and all these things, because of the expansion of the marrow. So because of that, you are typically seeing this typical chipmunk kind of a face. And what you are seeing in this picture is hair on end appearance. What you are typically again seeing is lot of hair-like projections are coming out, small. You can see like small hair-like projections are coming out. These are the expanded cancellous bone from the bone marrow. And what you are seeing here is typical lot of this mask-like things, because this is because of expanded ribs to increase hematopoiesis. This is a sign of extramedullary hematopoiesis as well. And again, what you are seeing here is, in these 2 slides, is again extramedullary hematopoiesis in the paraspinal region, which are actually, you can see there is a lot of spinal cord compression also because of this extramedullary hematopoiesis. These are the extramedullary hematopoietic tissues that are actually compressing on the spinal cord. So this patient is at risk of developing paraplegia as well. So many complications are there, so which can cause all these clinical features. Apart from that, there are 2 classical investigations are there. I told you all the investigation findings there in your initial differences between major, intermediate and minor itself. But if you ask me, investigations that are specifically done for diagnosis of thalassemia minor, or screening for thalassemia minor, or for diagnosis of thalassemia minor specifically, these are non-specific investigations. Number 1, these are not very specific. These are typically non-specific investigations. If you ask me what happens in minor, what are the investigations you can use? First one is in exam, what they will ask you something called a Menzer index. What do you mean by Menzer index? It is the ratio of mean corpuscular volume by RBC count in millions. So what they are telling is actually one of the most important DD for thalassemia minor. If you ask me, thalassemia minor is iron deficiency anemia. This is the most important DD for a thalassemia minor, because in both these conditions the hemoglobin will be 9-10, and both these conditions you will have a low MCV and all these things. Apart from that, the most important difference between, if you ask me, in a iron deficiency anemia and thalassemia minor, if you want to differentiate, the most important will be iron indices. If you ask me, the ferritin will be definitely low in iron deficiency anemia, whereas it will be normal in case of a thalassemia minor. So if you ask me, TIBC increased, thalassemia minor normal, transferrin saturation decreased, normal in thalassemia minor. Then if you ask me about soluble transferrin receptor, again increased in thalassemia iron deficiency, normal, which means all the iron indices tends to be normal in case of a thalassemia minor. Then if you take RBC count, it will be decreased in the iron deficiency, increase in case of a thalassemia minor. Then if you ask about the final nail in the coffin, that is your HB electrophoresis. This is what the confirmatory thing. In HB electrophoresis, again normal in case of iron deficiency, where you will have abnormality, that is HbA2 will be more than 3.5%. So this is what is suggested of a thalassemia minor, beta thalassemia minor. So beta thalassemia minor. So these are some of the difference between iron deficiency and thalassemia minor. But apart from that, both iron deficiency as well as thalassemia is going to show microcytic hypochromic anemia in the peripheral smear with little bit of anisopyclocytosis. At the same time, if you ask me about the red cell distribution width, it will be increased in case of a iron deficiency anemia, whereas it tends to be little bit relatively normal in case of a thalassemia minor. So these are some of the important points you have to note about difference between iron deficiency anemia and thalassemia minor. But apart from that, this Menzer index you can remember. Here the Menzer index, I didn't write there because it's not that important, but only important for exam. But in real life, it's not important. So Menzer index wise, if you ask me, MC divided by RBC count in million, if you put more than 13, that goes towards iron deficiency anemia. If it's less than 13, that tends to be something called a thalassemia. The reason why it is less than 13 in case of a thalassemia is because in thalassemia, the MC will be very much decreased, but the RBC count in thalassemia minor is actually increased. So that is the reason why it is less than 13. Numerator is decreasing but denominator is increasing. Then only you can diagnose it as a thalassemia minor. On the other hand, if you have iron deficiency anemia, why it is increased in iron deficiency anemia is because, or the ratio is maintained in iron deficiency because here the MC will be decreased and RBC count also will be decreased in iron deficiency. So that is the reason why the ratio is maintained and it is more than 13 in case of a iron deficiency. So this is what we call Menzer index. Second one, we have something called a Nestroft, that's called naked eye single tube red cell osmotic fragility test. We can see the Nestroft here. The basis of identifying this, understanding this Nestroft is very simple. I told you there are two types of RBCs are there. One is microcytic RBCs and second is spherocytic RBCs. There are two types of RBCs are there. So here in thalassemia, we are going to discuss on microcytic RBCs. But what happens if a normal RBC is put in a normal RBC? For example, if you take a like this biconcave shape, a normal RBC, what is going to happen is if you place in a hypotonic solution. So what is going to happen is the water is going to enter into the RBC and it's going to swell because water is going to enter into the RBC and it's going to swell. And to an extent, it can accommodate some amount of water. It can accommodate some amount of water inside. After some time, more and more, if you reduce the concentration more and more, if you further reduce the concentration of the hypotonic solution, finally at one point it will lyse. But at what point it lyses depends of what is the concentration of the hypotonic solution. But it can take up some water. Any RBC. But how much water it can take at what concentration? The more you reduce the concentration, more the water enter into the RBCs. That's what the base of hypotonic principle. How much water it can take and at what concentration it lyses, that's what is very important. Normally, if you ask me, microcytic RBCs, the principle is very simple. Here the content is very much reduced. The RBC membrane is very shrinked RBC membrane, and I can write the inside the cytosolic content, the hemoglobin is actually quite less. So that is why the cytosolic content is reduced. The cytosolic content is reduced because of that the membrane shrinks, but the surface area is normal. Here the surface area is normal, but actually the volume is actually reduced. Which means if you ask me about the ratio of the surface area and volume, actually it's increased in microcytic RBCs. Actually it is having relatively less volume compared to surface area, which means it can accommodate. When you place in a hypotonic solution, what happens is it can expand more, which means it can take up a lot of water because of the large compared to increased surface area to volume ratio. So because it can expand more and more. So which means if you take place in a hypotonic solution, it will lyse late only, or it will lyse at a concentration less than when a normal RBC lyses, because it can take up more volume of water. So the less hypotonic solution, which means what I can tell typically is the osmotic fragility is actually decreased, which means the fragile nature of the RB is actually reduced, which means it can tolerate more and more lesser concentrations of hypotonic solution. So that is why the osmotic fragility is actually decreased. But if you ask me about a spherocyte, how spherocyte is formed is if you have a normal RBC, when you remove a chunk of membrane from a normal RBC, you will get a spherocyte, which means in this patient the volume is normal in this RBC, but the surface area is actually quite less, which means the surface area to volume ratio is actually decreased in a spherocyte. So what is going to happen is when you put this water in when you put this RBC in a hypotonic solution, it can not take up any extra water because it's already full of content. The moment the water starts entering into this RBC, it is going to lyse. So which means spherocytes can't tolerate hypotonic solutions, which means they are going to lyse fast. Spherocytes will lyse fast, or they are going to lyse at a very high concentration itself. I mean, you are putting in a hypotonic solution, but higher concentration they will lyse. So this is what we call osmotic fragility is actually increase in case of a spherocyte, whereas decrease in case of a microcytic RBC. But what we are using this is actually a Nesterov test. But what principle we are using in a Nesterov test is like what will happen if you put the RBC in a hypotonic solution at a fixed hypotonic solution. At a fixed hypotonic solution of 0.3% buffered saline. When you put in this 0.36% buffered saline, what is the concept is at this point, this hypotonic solution. Now, I mean 0.9% normal saline is a isotonic solution where the RBCs generally don't lyse, but 0.36% is a much lesser concentration. Definitely, a normal RBC will lyse at this concentration. Normal RBC will definitely lyse, but a microcytic RBC, a very severely microcytosed RBC, like in a thalassemia patient, thalassemia minor, that's why we use this test, not for major, intermediate and all. In microcytic RBCs, this will not lyse at this concentration, which means they can take up more water since the osmotic fragility is actually less in these patients. So they will not lyse at this concentration, that's the idea. So that's why we're going to use this distilled water control, distilled water used as a control. Distilled water means it's 0%, no concentration at all. It's a totally hypotonic solution when you put RBCs here. So we'll put a normal RBC here and keep it as a control, where definitely at 0% normal RBC will surely lyse. There is no doubt about that. Any RBC will lyse at 0%. So whenever they are lysed, you can see the paper, there is a paper here that is where the line is drawn, and you can see this line very, very clearly on the back, which means this is a control. But when you put in buffered saline 0.36%, I told you similarly, if you put normal RBC at buffered saline, definitely again it's going to lyse, which means there is no difference. You are going to get a similar thing equal to that of the control. You are going to see the black line because here the RBC lyse because it's a normal RBC. I told you normal RBCs lyse at 0.36% buffered saline. But when you call a positive test, again you are having a control here, distilled water, where you have added a normal RBC from a normal patient and I have added 0% intentionally to know what lysis means. So here the RBC is completely have lysed and you are seeing a black line on the back of the, when the paper with the black line is kept on the back of the test tube, you are going to see the black line very clearly. But in this condition, why we call this a positive test is because suppose this is a microcytic RBC, it does not lyse. At 0.36% buffered saline, microcytic RBCs will not lyse. So since there is no lysis of this RBC, which means the solution still remains turbid and you cannot see the clear line at the back. So you don't see the clear line at the back of the test tube. And that line that is drawn on the paper is not seen visibly because it's turbid, because it's not yet lysed. That is the reason. So no lysis happens. So this, if you're not able to see the black line, this is what we called as a positive Nesterov test. So this is one idea about knowing the Nesterov test. And finally, what about the treatment of thalassemia? So if you want to know about the treatment of thalassemia, the most important thing is like regular transfusions. Regular transfusions means it's a lifelong transfusion in case of a thalassemia major. Lifelong means number one, you have a target hemoglobin which should be maintained at more than 10 grams per deciliter. And second one, what transfusion regimen we follow is something called a hypertransfusion regimen. Typically what we do is 2 to 3 units of PRBC, which will be typically transfused over 4 to 6 weeks time. So this is what we prefer currently, hypertransfusion regimen, to keep almost hemoglobin in the normal range, more than 10 grams per deciliter, to suppress all the complications due to anemia and extramedullary hematopoiesis. Second thing, definitely the moment you give these regular transfusions, you are at high risk of developing iron overload, so you have to do iron chelation also. How will you do this iron chelation is again very simple. So the moment you transfuse at least 10 to 15 units of PRBCs, if you have transfused 10 units of packed red cells, you have to start iron chelation. Very, very important fact. So otherwise the patient will go for risk of iron overload and related complications. So to avoid that, the moment you advance around 10 to 15 minutes, it's better to start with iron chelators. The target for this iron chelators is to maintain ferritin in the range of, that is serum ferritin in the range of somewhere around 1000 to 1500 nanogram per ml. So which means if you ask me what is the normal ferritin, it is approximately 20 to 100 nanogram per ml, which means you are maintaining at 10 to 20 times the upper limit of normal. So that is what you do, 10 to 20 times the upper limit of normal. That's what you are trying to maintain the ferritin, but still it's fine. You cannot reduce more than that also. That's very dangerous. But why this? This iron chelation is done to reduce prevent the iron overload. It is done to prevent the iron overload. But why can't phlebotomy? Can you do phlebotomy? Yes, you can do, but whether you can do in thalassemia. In iron overload, phlebotomy is indicated or not? Answer is yes, but why not in thalassemia? Remember, phlebotomy is contraindicated in thalassemia. If you ask me where one of the important contraindications for phlebotomy, the answer is anemia. Anemia patients, you can't do phlebotomy. In hereditary hemochromatosis, there is no anemia. There is only iron overload. So in those conditions, you can try a phlebotomy. But in this thalassemia patient, already patient is severely anemic, and how we can do phlebotomy and remove blood in an already anemic patient? Not possible. So phlebotomy is contraindicated in any anemia patient, even with iron overload, and especially in thalassemia you can't do. You can only do iron chelation for this iron overload. You can't do anything else. So what are the iron chelators that are available? There are 3 iron chelators that are available. One is called deferoxamine. Second one is called deferiprone. And the third one you have something called a deferasirox. Deferasirox. There are each and everything has some unique properties are there. But that's what we're going to see now. The first unique property is the chelator to iron ratio. Chelator to iron ratio, the first one. So deferoxamine as typically in the ratio of 1:1, very efficient, 1 molecule to 1 molecule, 1:1 ratio, whereas deferiprone in 3:1 ratio and deferasirox 2:1 ratio, which means most efficient is deferoxamine only, quick and efficient. And second thing, if somebody asks you the route of administration, again your deferoxamine is IV, deferiprone and deferasirox are completely oral, but deferoxamine is IV. And third thing, if somebody asks you about the half-life is very short here, moderate, intermediate, and very long half-life here. So typically, like it's in minutes, it's in long means it's in days actually. It's in hours, half-life. So which means what I'm trying to tell is, since it's IV and it has to be given as infusions, very important, it has to be given as infusions. Since it's IV and infusion and it's a short half-life and very effective, 1:1 chelator removal ratio, chelator to iron removal ratio, all these properties make this deferoxamine suitable for acute iron overload. Acute iron overload, acute toxicity. For example, the best example of acute toxicity is a child ingesting like 100 tablets of ferrous sulfate tablets. Iron tablets he has ingested. This is a simple example of a acute iron overload. So deferoxamine becomes a very easy choice for an acute iron overload. But a chronic iron overload, what we prefer is a deferasirox. For a chronic iron overload like thalassemia or in conditions like hereditary hemochromatosis, we generally prefer deferasirox. The reason is, one important reason is oral, a better ratio compared to that of the deferiprone. At the same time, the fourth point, if I tell you, will understand more, what is the dosing. If you ask me, I told you this has to be given as continuous infusion, but whereas this can be given as tedious doses, this has to be given as OD dose. So the OD dosing is the one that is the key. OD dosing, oral, better compared to deferiprone, among the oral, better compared to the deferiprone. All these things make deferasirox the best choice for chronic iron overload patients like thalassemia. And if you ask me about the side effect profile, side effect wise, if you ask me, lot of side effects are there for deferoxamine. They can produce skin irritation, they can produce retinal toxicity and eye related problems. They can cause high tone deafness, high frequency hearing loss. Then they can result in growth retardation. And very importantly, I believe the only important point that is needed for the exams is this deferoxamine has increased risk of Yersinia infections. This is what is very important for understanding. Increased risk of Yersinia infection. So why these patients are having increased risk of Yersinia infections? Because Yersinia uses this deferoxamine as a siderophore. Yersinia is going to use this deferoxamine as a siderophore. That is the reason. Apart from that, very important. They can have pulmonary toxicity also in long run. All these things are possible. So usually rare with oral drugs, but they can develop agranulocytosis deferriprone, and they can produce arthralgia, arthritis, erosions and all, erosive arthritis and all these things are possible with deferriprone. But usually mild gastrointestinal side effects only is seen with deferricirox. So usually oral compounds have very little side effects compared with deferoxamine, IV drug. So that's why we prefer deferricirox as a choice most of the times. But one advantage of deferriprone, if you ask me, this is also an exam question. One advantage of deferriprone, it is better for cardiac iron, better for removing cardiac iron, which means the iron is deposited in the heart. This deferriprone has shown to be more efficacious in removing the cardiac iron overload compared to other drugs, even deferricirox or deferoxamine itself. So that's why in this condition deferriprone may have an edge, but in general we use deferricirox as a first line drug. So these are the important things. Apart from that, other treatment options, if you ask me, in a thalassemia major, you can go for splenectomy. Splenectomy typically done after 6 years of age, don't do before that, and usually the indication for splenectomy is only one. Even though massive splenomegaly causing chronic abdominal pain is given in the textbooks, but that doesn't mean you have to do splenectomy, and generally nobody does for that reason clinically. The most important indication is increase in the transfusion requirement. Increase in the transfusion requirement by at least 50% in 1 year. So which means this, because of hypersplenism, whatever transfusions you give, it's going waste into the spleen only. So in those conditions, if the transfusion requirement increases by 50% in 1 year, then you can do a splenectomy, that too after 6 years of age. Otherwise there is no indication of splenectomy in a thalassemia. Many times then immunization plays a key, because these patients are at risk of lot of infections, like HPV and all. Better to vaccinate them. If you are planning for splenectomy, to prevent capsular organism infections and sepsis, OPSIs after splenectomy, you have to vaccinate them prior to that with Hib, pneumococcal, meningococcal vaccines and all, which are again very important. And stem cell transplant you can use, but again this is a curative option, but very limited experience is there, but it's very difficult to do also, that's why. But it's a curative option. It's the only curative option available for thalassemia. Then you have treatment of EMH and leg ulcers. EMH, extramedullary hematopoiesis and leg ulcers. How you are going to treat this is, there's one drug called hydroxyurea, which can also be called as hydroxycarbamide, which is very helpful. Which is very helpful in EMH and leg ulcers. Plus or minus you can do regular transfusions, and because of anemia itself these things happen. That's the theory. So when you prevent this anemia, regular transfusions, you can suppress this extramedullary hematopoiesis and leg ulcers. Remember, these are very common. I told you already. Again, final point. These are common in intermediate than major. All these EMH and leg ulcer related complications are very common in intermediate than major. So in these patients you can use this treatment specifically if at all needed. Hydroxyurea or plus or minus regular transfusion. So all these things are very important. So we have some minor variants of thalassemic variants are there. So the most important thing in that is we are going to discuss on the hemoglobin lepore and anti-lepore. So let me tell you normal. What is normal? HB, lepore and anti-lepore. So this is also very important to understand. This is genetic based, and again sometimes asked in exams about all this. So what do you mean by hemoglobin lepore and hemoglobin anti-lepore? Before that, let us see the basic structure of hemoglobin. Basic beta globin gene. So whenever you think about where is the beta globin gene, you have the last one is the beta globin gene in this chromosome. So what is going to happen is you have initial epsilon, then you have the gamma 2 have your G gamma and A gamma, then you have delta gene, and finally you have our ever important beta gene. So this is the arrangement in the chromosome. This is the arrangement of the genes in the chromosome. So what happens is, normally itself there will be some process called crossing over will happen. Normally itself when there is a crossing over, there will be equal crossing over will happen between both the genetic fragments, and you will result in a completely normal entity, which means there is no difference at all, no difference. At the end, only, like the genetic material will be some change in the genetic exchange in the genetic material will happen during meiosis in mom and dad, but the amount of the genetic material will not change. The quantitatively, the amount of genetic material that is exchanged is the same, and there is no difference in any quantity of the genetic material that is seen in both the exchanged DNAs. So this is a normal crossing over. So when you come to abnormal, so which means what you're going to see is what if an unequal crossing over happens. What if an unequal crossing over happens? So which means what you can see here is your beta is correlating delta, because it is shifted by this lower one which I have shown here is little bit shifted to that side, towards the right side in this example. So in this you can see the beta and delta are actually opposing, and they are the ones that are crossing over. But normally this should not happen. The beta should cross over with beta, delta should cross over with delta. Only some genetic material exchange, but the quantity should be the same. But here abnormally what is happening is the delta and beta are crossing over, and the beta in one area, the one gene, the beta is in excess, that is not getting crossed over at all. So this type of unequal crossing over, what will result in two types of fragments, DNA fragments. This is called, one is called a Lepore strand and another one is called a anti-Lepore strand. So what do you mean by Lepore strand is, so you get a epsilon, gamma, all these are fine, but this if you see this beta and delta are getting exchanged, because of that this beta and delta are seen. That's all. It's a short one. It's a shorter one. And what you are seeing in this anti-Lepore strand is an anti-Lepore strand. Again you are getting a beta and delta, and this excess beta is also coming along with the anti-Lepore strand. So which means this is unequal division. That's what I mean. Unequal division. One is getting little, one is getting excess. And both are having this beta and delta crossover, but one is having the excess beta that is not getting crossed over at all. So that's what we're going to call as anti-Lepore strand. One is little, one is excess. But what is the problem in this Lepore strand? And why this anti-Lepore strand, what problem it can result in? Let me tell you. So in Lepore strand, the problem is it will result in thalassemia. How? Because I told you, if you take each and every gene, for that matter, if you take all the genes, each and everything are genes, and everything has a promoter sequence. Everything will have promoters. Every gene will have a promoter sequence. Normally, if you ask me, the beta gene promoter is the one that is more active. Activity of the beta gene promoter is the one that is too much. That is the reason why in adult life your beta globin, that is your HbA, that is alpha 2 beta 2, is the one that is dominating. Why beta is dominating in adulthood, not gamma? Because the beta promoter activity is very good and very high, and the delta promoter activity is very little, very, very poor. It's not that much at all. But that is a problem here. If you ask me in a Lepore strand what happens, you can very clearly see this anyway going to produce an abnormal beta chain, that is beta, delta, some hybrid chain it will produce. At the same time, you can see that the promoter that is responsible for transcripting this aberrant delta beta gene is under the control of delta gene promoter. Normally I told you the delta gene promoter is generally less active in adult, which means it's active only up to 3 to 5%, which means only 3 to 5% of transcription will happen, remaining will not happen. So that is the problem with this Lepore strand, and this is what we call HB Lepore. So they produce this hemoglobin, aberrant hemoglobin, HB Lepore, which is a hybrid, which will not have a beta chain, it will be alpha to beta 2 only. But this will be a Lepore strand, which means this beta chain that they are going to produce will be an aberrant Lepore strand. Will be an aberrant Lepore strand, and the amount of HB Lepore quantitatively, if you ask me, that is also is less. Quantitatively, if you ask me, that is also very, very less. The reason why quantitatively it is very less is because I told you already, the delta gene promoter is less active, and that is the reason why the amount they are going to produce also very less, and that is the reason why this Lepore strands can result in thalassemia. For example, if the Lepore is homozygous, which means both are Lepore, inherited from both the mother and father, it's going to result in something thalassemia intermedia like picture, or if the Lepore is heterozygous, which means only one gene is affected with Lepore strand and another one is completely normal, they are going to result in a thalassemia minor like picture. So clinically speaking, so this is how they are going to present. Remember again I told you intermediate or minor doesn't have anything to do with alpha or beta alone. They can be seen in any condition. It's a clinical classification only, not a genetic classification. Genetically Lepore can produce minor, Lepore can produce intermediate, even beta can produce intermediate, beta can produce minor, beta can produce major, alpha also can produce major, alpha also can produce minor, beta also can produce minor. So minor, major, intermediate are clinical classification only. It is nothing to do with the genetics, so don't get confused by that. So homozygous Lepore will result in trait, intermediate like picture, and heterozygous Lepore will result in thalassemia trait like picture, minor like picture. So what about this anti-Lepore strand? Suppose if inherit an anti-Lepore strand, is there any problem? No. Anti-Lepore strand will have normal HBA at the same time both qualitatively as well as quantitatively. Whereas in Lepore, it is affected both qualitatively and quantitatively. Quantitatively less is produced, qualitatively it's a hybrid strand. But here both quantitatively and qualitatively it will be normal. Why? Because here is your beta globin gene promoter and it is normally located before the beta gene. So they will produce normal amount of beta genes. Nothing to worry about it. So they are going to be completely normal. So inheriting an anti-Lepore will not have any clinical consequences. They will be completely asymptomatic. So this is what you have to know. So the next thing what you have to know is the delta beta thalassemia. So this is, we are putting the final nails in the coffin. This is what we called as a delta beta thalassemia. So what happens in delta beta thalassemia, and importantly, you know very well this delta and beta genes are, all these genes are seen what, chromosome number 11, very important. So what about this delta beta thalassemia? For this to understand, let us put another picture. I told you like you have epsilon, you have this 2 gamma chains, A gamma and G gamma, and you have a delta gene and you have a beta gene. So this is the sequence that you see on the chromosome number 11. So what if these genes are deleted? What if these genes are deleted? So this delta and beta genes are deleted. This is what we called as delta beta thalassemia, where delta and beta genes are completely deleted. This is a deletional type of thalassemia. So this is what we call delta beta thalassemia. So we can see what happens in homozygotes and what will happen in heterozygotes. So if you see this picture, this is what is happening, this is what a homozygous, this is what we called as a heterozygote. In homozygotes you can see this delta beta is deleted in both the mom and dad genes, dad chromosomes. And whereas if you see here, only mom or dad, anyone is deleted, the other delta beta is actually normal located. This is what we call heterozygous. This is what we've been discussing for quite a long time from the alpha thalassemia last section part. So what happens in homozygous? What will be the clinical features? If you ask me difference between delta beta thalassemia and homozygotes as well as heterozygotes, clinically if you ask me, they will come with a thalassemia intermediate like picture. Here they will come with a thalassemia minor or a trait like picture, because one is completely normal. So then if you ask me the HbA2 levels, typically 0%, absent. Here it will be very much reduced, less than 3%. Why HbA2 is absent here? Because HbA2 means alpha 2 and delta 2. Here there is no delta gene at all. How can I produce HbA2 in both the chromosomes? Here only one delta is decreased, other one is normal at least. So it will be there but will be decreased because one delta is deleted. So it will be less than 3%. Then if you ask about HbA, again it will be absent, 0%. The reason is again because there is no beta gene in both this, gone, no beta in both. But here at least one beta is there. So that is the reason why it will be decreased, but approximately around 80% will still be there, but not completely, not like 100% normal. So then if you ask about HbF, it will be increased and it will be 100%, because the only hemoglobin that can be produced this is gamma. That's all. They don't have, in homozygous, they don't have any delta or any beta. They can't produce HbA or HbA2. They can produce only HbF. That's why the entire 100% will be hemoglobin F only. And what about these heterozygotes? These heterozygotes, if you ask me in this HbF will be increased here also, because definitely in one gene this will produce only HbF from this chromosome. From this chromosome you are getting HbA as well as HbA2. But since only one chromosome is producing this, it will be decreased. Both will be decreased. Since this is producing HbF only, the HbF levels will be increased. So how much it will be increased? Typically in the range of 5 to 20%. So this is the idea. So the most important DD for this heterozygous delta beta thalassemia. So whenever you think about this, whenever you talk about this heterozygous delta beta thalassemia, the most important differential diagnosis for this heterozygous delta beta thalassemia is what we refer to as something called hereditary persistence of fetal hemoglobin, otherwise referred to as something called HPFH. That's called hereditary persistence of fetal hemoglobin. So what are the reasons where you can get in hereditary persistence of fetal hemoglobin? Actually, usually this HPFH is a very benign condition. I'll tell you why it's a benign condition. So you have two types. One is called deletional forms, and second one is called non-deletional forms. So in deletional forms, the reason is you have, I told you, epsilon gene, 2 gamma genes, and you have delta gene and beta gene. So what if the beta gene is deleted? So beta gene deletions. I told you, since the beta gene promoter is the one that is active in adult life, deletion of the beta gene and the associated promoter cannot work. So relatively your gamma chain synthesis will increase. So that is the reason why HbF will increase. Remember, this is not delta beta thalassemia. This is due to beta gene deletion only, not delta beta thalassemia. Delta beta is both delta and beta are deleted. Here the delta is okay. So this is what we call one deletional example. Non-deletional HPHF usually you result in, I told you similarly, epsilon, you have G gamma, A gamma, then you have a delta and a beta. And when you link everything in a chromosome form, and everything has a promoter, I told you. Promoter is there. And what if the promoter mutations happen and it's a gain of function mutation? So which means this promoter gets more functional and the transcription will actually increase than necessary. So which means again it's going to increase the HbF. Normally it should not be that active during adult life, but what if the some mutations is causing this promoter to work more than necessary, and you are going to produce more gamma chains and you are going to result in increased HbF. This is what we called as a hereditary persistence of fetal hemoglobin. If you ask me what will be the feature of one of the important feature of this hereditary persistence of fetal hemoglobin, what will really happen is, typically you will see a harmless increase in HbF. A harmless increase in HbF will be there, which means there will be no clinical feature and the patient will be completely asymptomatic. Apart from increase in HbF, you don't have any other problem at all. Sometimes even HbF can be 100%, but there is no problem at all. Clinically, completely normal, no clinical feature, completely asymptomatic. It's a completely harmless increase in HbF will be there. Usual HbF levels in hereditary persistence of fetal hemoglobin will be in the range of again 5 to 30%. That is the reason, because you know very well, here you have 5 to 30% HbF. Even in delta beta thalassemia heterozygous variant, again it is in the same range of 5 to 20%. This patient, since they are delta beta thalassemia heterozygous, is presenting with thalassemia minor, which means they are asymptomatic, and this patient is also asymptomatic. Asymptomatic, decrease HbA in both and increase HbF in both, almost in the same range. So that is the reason why this heterozygous delta beta thalassemia is one of the major differential diagnosis for this hereditary persistence of fetal hemoglobin, because both are asymptomatic, both are having little bit reduced HbA, and both are having relatively increased HbF almost within the same range, and both are asymptomatic clinically. How you are going to make out? So very simple. So the idea to make out difference between these two factors, the only condition that has pancellular distribution of HbF, which means HPH, the hereditary persistence of fetal hemoglobin, is the only condition in the world that has pancellular HbF, or otherwise referred as homogeneous HbF distribution. Homogeneous HbF distribution, which means every single cell, if you take an RBC, 10 RBC in this example, all the RBCs will have same amount of HbF. This is what we refer to as something called a pancellular or homogeneous distribution of HbF. But all other conditions that increase HbF, for example, you can call it as a delta beta thalassemia. If you take 10 RBCs in this condition, only few RBCs may show increased on, RBCs with HbF. Only few RBCs may have HbF, other RBCs may not have HbF. So this is what we refer to as heterocellular distribution, not a homogeneous distribution. So this is what we are going to utilize to differentiate between a hereditary presence of fetal hemoglobin versus a heterozygous delta beta thalassemia. So how you can do easily traditional testing. Traditionally, how you can differentiate is based on some testing called Klehoer-Betke test. Klehoer-Betke test, where in Klehoer-Betke you would have studied like something called an acid elution test. Acid elution, where what you have seen here is this is one of the quantitative tests where you can quantify the amount of anti-D given to the mother in times of Rh incompatibility. When the mother has Rh incompatibility, how much anti-D to be given. For quantification also you can use this test, where this based on the principle when you add acids like hydrochloric acid to the blood. For example, take mother's blood. Suppose when you add hydrochloric acid, let us assume these are the RBCs in the mother's blood. So when you add hydrochloric acid to this mother's blood, what will happen is, so let us assume this hydrochloric acid will elute out, which will remove the HbA. After that, if you counter stain and see, only initially when you stain, everything will be having hemoglobin. The moment you elute out HbA by giving hydrochloric acid, when you add hydrochloric acid, the HbA can be eluted out of the RBCs. So which means if you see all the RBCs with no stain at all, it means that no fetal RBCs are mixing, no fetal RBCs are present. No fetal RBCs are present in this mother's blood. Suppose on the contrary, you have a similar picture, and you are doing something very similar, and you are adding a hydrochloric acid or some acid, strong acid, and which means when you add an acid, you are eluting out the hemoglobin A out of that particular peripheral smear. And now if you see something similar to this, what does that mean? Because these are the fetal RBCs. Which means what I am trying to tell is the hemoglobin F cannot be eluted by HCl, which means still HbF is acid resistant and it still is going to persist. This Klehoer-Betke test is one of the standard tests. This is a very tough test but cumbersome, not so reproductive. You cannot reproduce this test in every single specimen, but even though it's one of the classic traditional tests that is used for identifying the mixing of the fetal RBC with the maternal RBC to quantify the amount of anti-D given in case of a Rh incompatible fetus. So this is what we use, but the same principle we can use in the hereditary person of fetal hemoglobin also. In hereditary persons of fetal hemoglobin, same principle you will see. What you will see in hereditary person of fetal hemoglobin is, if you do something initial staining, for example, you take the 6 RBCs, all these are going to have staining with hemoglobin. There's no doubt about that. But when you add hydrochloric acid to this solution, you know very well, similarly all these cells are going to have equal amount of HbF distribution. There is no doubt. So this is what is going to happen. But if you have a delta beta thalassemia, you will have initial staining is going to be there, definitely in delta beta thalassemia. But when you add hydrochloric acid and elute out the HbAs, what you will be seeing is only a few cells showing staining, which means HbF is present only in certain cells, whereas in hereditary person of fetal hemoglobin, your HbF is seen in all the cells. This is what we refer to as something called a pancellular HbF distribution, and this is what we refer to as something called a heterocellular or non-homogeneous HbF distribution. But if you ask me such a cumbersome test should be used or not, answer is no. Instead, how will you differentiate between these two? Easily is by using a flow cytometry. So what you're going to do is a flow cytometry picture. That's it. I've clearly shown you what you mean by a delta beta thalassemia and how to differentiate hereditary person of fetal hemoglobin. Very simple image. In hereditary persons of fetal hemoglobin, what you are seeing in flow cytometry, because in one area I am putting the HbF and I'm going to counter stain with fluorescent anti-HbF. That's how we do a flow cytometry. And you can see the counts here. There is a lot of cells, a high amount of cells are showing only a single peak, which means these are all having cells with very high amount of HbF is there, high amount of HbF, and the cellular count is also very high, only single peak is there. All of the cells are showing a single peak homogeneous HbF distribution. But if you see in delta beta thalassemia, what you are categorically seeing is there are two populations of cells are there. One is very low level of HbF, one population with low level of HbF, and another population with high level of HbF. So you are seeing two populations. One population with some amount of cells are there with low level of HbF. Another population is there which is relatively less in number, which is seeing high level of HbF, which means there are cells without HbF and there are cells with HbF, which means this itself in flow cytometry shows that the patient is having heterocellular distribution. This typically goes towards delta beta thalassemia, and for that matters, apart from hereditary persons of fetal hemoglobin, every single disease that produces increased HbF in hemoglobin electrophoresis is going to have this kind of picture only, this kind of heterocellular distribution like beta thalassemia only HPFH, that is hereditary persons of fetal hemoglobin, only will have this classical pancellular or homogeneous distribution of HbF, where you will get a single peak in flow cytometry, where you will have two peaks in case of heterocellular distribution or pancellular distribution. This is the difference in flow cytometry between delta beta thalassemia and hereditary persistence of fetal hemoglobin.